Good evening to one and all. At the onset, I would like to extend a warm welcome to our eminent presenter for this evening, Dr. Subhashish Roy, and all the HCPs who have joined the live session. Lupin salutes all the frontline warriors of COVID-19 and wish that they should be healthy and safe. In the quest of dissemination of knowledge, we have Dr. Subhashish Roy, who will share his wisdom on the topic of poorly controlled asthma in children. There is a change in approach. Dr. Subhashish Roy is MD DCH. He is an eminent child specialist with pulmonologist in Kolkata, and he is associated with Columbia Asia Hospital, Kolkata. So now, sir, I am handing over the session to you. So the stage is yours, sir.
Thanks, Romak. Good evening, everybody. Thanks, the team Lupin. Thanks, Romak, for your kind introduction. Let me start with sharing the screen. Just 1 second. I hope the screen is visible.
Yes, sir, screen is visible.
Yes, sir. Yes, sir.
Okay, fine. So there are a lot of talk regarding the management of asthma, and especially those who are young pediatrician. Now they have started the asthma clinic or going to start an asthma clinic. Many of the times in last 30 years of experience, we have seen very subtle things can make the life of ours very difficult, because treating the asthma in children is not a very easy job. It's labor intensive, and you have to devote a lot of time for each patient to get a success, because it is not a tablet or syrup which can be gulped and the result is there. Because you have to take care of whenever you are prescribing inhaler, and most of the asthma cases are being treated with inhalers. So whenever you are prescribing inhaler, you have to give a demonstration with the length of time. You and your assistant in the clinic may have to devote a lot of time. And whenever the child in follow-up is coming, you have to again see whether the child is taking the technique is correct, whether the dose is correct. And more so, you have to ensure with some objective assessment and some subjective assessment as well, whether the adherence of the child with the or the family with the therapy is there. Because otherwise, if the adherence is not there, however good you are as a physician, your whole effort will be wasted. So we are going to discuss the poorly controlled asthma in children, whether we should change in approach. Now, poorly controlled asthma, there are a lot of terms associated with that. That is a poorly controlled asthma, difficult control asthma, therapy-resistant asthma. And all of you know that some of the asthmatics are genetically predisposed that they are resistant to inhaled corticosteroids. But that's a very small number of children. And in today's talk, we are not going to discuss that small gamut of the children who are therapy resistant or steroid resistant. That's a job of pediatric pulmonologist and not the job of the general pediatrician. So, just 1 second. So in introduction, this is a childhood asthma and its impact. Childhood asthma causes considerable morbidity, especially during periods when it is insufficiently controlled. And that is very true. If the child is coughing, if the child is not sleeping, if the child is unable to go to school, then the whole family gets upset. The child academically is not up to the mark, mentally gets depressed. And in this group, when it is insufficiently controlled, it has been found that close to 50% of the children, when they are not properly controlled, they complain of limitation of activity and sports. The child otherwise is not coughing that much, but the child is unable to run or play. And whenever the child is climbing a stairs, the child starts coughing. Secondly, almost 1/3 of the children complain of nocturnal awakening due to asthma. And almost half of them, because they cannot sleep at night, because they cannot do normal activities, their regular attendance to school often becomes difficult. Now, symptoms and consequences of asthma disease activity, what are the type of symptoms? The most common symptom is cough. The children cough. And these children, most of the parents complain that my child starts coughing. Most of the cases, the cough is a dry cough. The cough is more at night. The cough is increased by activity. And whenever the child coughs, some of the children, especially the younger children, they start vomiting. Second, you can hear the wheezing sound, a whistling sound, and it will be, if you put a stethoscope on the chest, you will get a polyphonic sound. That means all the sounds are not of same pitch. Some is higher pitched, some is lower pitched, because involvement of the airways in asthma are heterogeneous. It can involve the medium-sized airways, it can involve the smaller airways. So the wheeze will be audible, and if you put a stethoscope, you will find polyphonic wheeze. Shortness of breath, as we have discussed, the child is unable to do the daily course of activities, and chest tightness especially is complained by older children. Younger children usually do not complain of tightness of chest. Use of rescue medication whenever, if you have advised inhaled short-acting beta agonists, then the use of rescue medication. Use of daily controller medication, mostly by inhalation devices. Now, the pattern of symptom is mostly they are nighttime symptoms. The child may cough in the daytime, but it is exacerbated at the night. Second, it is more during activity while the child is playing or the running, or in younger child when the child is crying or laughing or talking very loudly. And there can be a seasonality. That means, and in India, mostly the cough are exacerbated, or there is an exacerbation of asthma during the winter and during the rainy season. The impact of the symptoms are manifold. There is limitation of activity, which we have already discussed, and almost 50% of the children, if they are uncontrolled, suffering from uncontrolled asthma, they suffer from limitation of activity, play, and daily activities. I still remember a child who was slightly obese, but the mother used to take the school back 1 year back when the lockdown was not there, when Corona was not there. The mother controlled that the mother will carry the bag, school bag, up to the third floor where the class was there in the school. So limitation of activity, play and daily activities are severely hampered. Absence from school if the child is not sleeping at night. And as a consequence, if the child is not sleeping, the child is sick, the parents, especially the mother, unable to attend the normal, if the mother is working mother, she has to remain absent from the work and impact on sleep. Now, goals of the asthma treatment are basically three. Go to GINA or go to ATM. Everywhere, there are three goals. One, if the child is having symptom, you have to control the symptom. Second, you have to reduce the future risk of admission and exacerbation, or which is commonly known as a flare-up. And third, enable the child or enable the patient to lead a normal life without restriction. If the child, you have controlled the cough, but the child cannot play. So you have not controlled the disease in a proper way. So the child should have a normal activity without any restriction, no future risk of exacerbation, and maintain a clinical control and reduction in symptoms. So confirming the diagnosis, all of us know confirming the diagnosis, asthma is basically a clinical diagnosis. Most of the cases, more than 90% of the cases, we diagnose asthma by only clinical features, by symptoms, signs, and history. The diagnosis is usually suspected on the basis of typical history, the symptom, wheeze, breathlessness, and chest tightness. These symptoms, however, are not pathognomonic of asthma, and the clinical picture can be variable. In younger children, the child may cough when playing or laughing. Older children, maybe not coughing at all during the daytime, only coughing at night. And a number of tests can be used, like spirometry, like peak flowmetry, like impulse oscillometry in very young child. A number of tests can be used to evaluate the asthma, but again and again and again, asthma is a clinical diagnosis. No single test confirms or excludes the diagnosis, and of course, for last 10 years, we are using FENO, that is fractional excretion of nitric oxide. Now, alternative diagnosis, this is basically a list of comorbidities plus asthma mimics, like bronchiectasis, cystic fibrosis, primary ciliary dyskinesia. The cough will be wet cough. And if you are getting repeated and recurrent attacks of wet cough, definitely you are not dealing with a case of asthma. And a child who is not losing weight, there is no failure to thrive, there is no other symptoms other than a persistent wet cough, there is no fever, the commonest diagnosis will be persistent bacterial bronchitis. But on the in this list, 1, 3, 4, they normally present with a wet cough. And by that history, you can exclude, no, it is not a case of asthma. Extrinsic allergic alveolitis, or which we know commonly say as a hypersensitivity pneumonia, you can get a very strong correlation with the allergen exposure. Like if there is a bird, if there is something, there is a exposure to chemical or fumes and repeated exposure, then you can get the features of extrinsic allergic alveolitis. Inhaled foreign body, here you will get a monophonic sound and there will be a lateralizing sign. That means the wheeze will be audible only one side of the chest and it will be monophonic, it will not be polyphonic sound. Now, gastroesophageal reflux, it's highly a debatable issue. Now, gastroesophageal reflux, whether it is a co-traveler or it is a comorbidity, there are a lot of debates on that, but it can be a common association because many of the studies it has been found that treating the gastroesophageal reflux does not improve the symptoms or the management of the asthma. Vocal cord dysfunction, yes, it is a very important differential diagnosis of asthma, but it is normally found in older children, especially in adolescents, more in the female. And these children, the wheezing is more common and more intense during the inspiratory phase, and the wheeze is maximally audible in the throat, not on the chest. And there is an adduction during your inspiration of the vocal cords. Normally what happens when we take an inhalation, the abduction of the vocal cord happens. But here the vocal cord actually adducts during inspiration and a wheezing sound is formed. And the therapy is not inhaled corticosteroid, neither short-acting beta agonist. It is a speech therapy and a visit to the psychiatrist are necessary. So it is a multi-pronged attack on the disease you have to do in vocal cord dysfunction. Hyperventilation, panic disorders, or habit cough, or psychogenic cough, they may mimic asthma because they are all present with a dry cough, but the history and observation of the child and examination of the chest can clinch the diagnosis. Allergic rhinitis exactly is not an feature of alternative diagnosis of asthma. It is basically a comorbidity. But in allergic rhinitis, you can get a dry cough because of upper airway cough syndrome, or it is postnasal drip, which we commonly say. If there is postnasal drip, the child will cough. Now, this is a very famous chakra of Jina, and there are three aspects of this circle. One is your assess. When the patient is coming, you have to assess. Then you have to adjust the treatment and the review of response when the patient is coming for follow-up. So what you have to assess when the patient is first or the child is first coming to you, whether you are correct in your diagnosis or not, symptom control and risk factors, including the lung function, if you have started the therapy, and if you have done the lung function, whether you have, there is an assessment, the assessment should be whether the lung functions are properly controlled or not, but that will more evident in the review response. Inhaler technique and adherence, that should be again reviewed during the review response, but during the initial assessment, you have to see that, and you have to give a cafeteria choice if it is possible. That means in an adolescent, you can give the child the options of the inhaler techniques. So you can give dry powder inhalation, you can give a choice of dry powder inhalation, you can give a choice of breath actuated inhalers. So for as the adjustment of the treatment, it is pharmacological and non-pharmacological, that means the asthma medications, and non-pharmacological exercise, that is breathing exercise, activities, and so far as if the child is obese, then you have to cut down your weight and doing some physical activities and treat all the modifiable risk factors. So modifiable risk factors, like if the parents are smoking, if there is a mold in the wall, if there is a damp wall, if there is agarbatti dhuna in the room, the incense sticks, they are very, very strong. In fact, one mosquito coil is equivalent to 100 cigarettes. So you have to take care of the modifiable risk factors, and you have to take care of the irritants and precipitants. Now, when the child is coming for a review, you have to see whether you have controlled the symptoms, whether there is any exacerbation between the period you have seen last and this visit, what are the side effects of the medication that you have advised, whether the parents, there is a level of satisfaction in the parents, whether the parents and the child is satisfied. That means satisfaction is very, very important, because if they are not satisfied with your protocol, so because you have given so many drugs, one 4 times, one twice, one thrice, the patient will be completely perplexed. So they cannot follow your advice. They are not satisfied. And if possible, if the child is grown up, then you have to do the lung function to objectively assess. So what is an asthma control? Again, we have already discussed this thing. The level of asthma control is the extent to which the features of asthma can be observed in the patient or have been reduced or removed by treatment. But basic goal for asthma control is a symptom control, whether the child is free from symptoms. This is number one. Number two, reduction in the future risk of exacerbation. And the last one is your whether the child can perform, there should not be any limitation of activity. So asthma control is assessed in 2 domains, whether there is any control of the symptom, future risk of adverse outcome, and the last one is that whether the child can perform normal activity and lead a normal life. Now, what is asthma severity? Now, there are a lot of severity assessment in the asthma, and this is quite perplexing, because initially, when we go through the GINA, we put a child based on the severity assessment. So it is a bit confusing for the young practitioner who are entering into the domain of treating pediatric asthma. So asthma severity is assessed retrospectively. That means what has happened in last 1 or 2 months or 2 to 3 months. So how the child was at that point of time, by history, we like to assess. And from the level of treatment required to control the symptoms and exacerbations. So if the child is extremely unwell, if the child is coughing almost daily, if the child is waking during the night, if the child cannot play for last 2 to 3 months, we have to put the child in a box where the child needs a controller therapy. It is important to distinguish between severe asthma and asthma that is uncontrolled, that is due to incorrect inhaler technique and poor adherence. Now, severe asthma and asthma uncontrolled means you have initiated the therapy, but the child is not improving. And severity of the severe asthma means the child is coughing every day, the child is waking up every day, the PEF is very bad, the FEV1 versus FVC is less than 90%. So all these factors, if are there, so that's a severe asthma. So what are the levels of control? So basically, we assess a child regarding the control by 4 parameters. One is daytime asthma symptoms more than twice a week. In a week, whether the child is coughing more than twice, that means the child is coughing on Monday, Wednesday, and Friday, then it is more than twice a week. Night awakening, any of the day, the child getting up from the sleep, that is a bad indicator. There is a bad control of the asthma. Need for reliever of symptoms more than twice a week. The child is coughing, but the cough is very mild. The mother can tolerate the cough, and it is not requiring short-acting beta agonist. So that's a very mild asthma. And limitation of activity. The child cannot play, the child cannot run, the child cannot climb stairs. So if at all they are any, that's a very serious limitation or serious loss of control so far as asthma is concerned. So either of these 4 parameters, if none of them are present, then the child is very well controlled. You need not worry with this child. If 1 or 2 of them are present, that is, suppose the child is coughing more than twice a week and the child is waking night time, but not requiring reliever, not requiring limitation, there is no limitation of activity, then it's a partly controlled asthma. And if more than 3 are, all the 3 boxes are ticked, then it is an uncontrolled asthma. So you need to take care of this child very seriously. Now, we have already discussed there can be subjective assessment, that CACT, SEQ, quality of life assessment. All these parameters are there, but I am not going into the detail because of want of time. But there are objective measurements of asthma control, and the spirometry is one of them. And regarding the spirometry, there are a few benefits, and there are some pros and some cons. In the spirometry, you can objectively assess. It is a non-invasive. It is helpful for the diagnosis. FEV1 and FVC ratio. FEV1 by FVC ratio can predict asthma-related morbidity and mortality even when FEV1 is still normal. That is FEV1 by FVC if it is less than 90%. Then definitely there is limitation regarding the airway passage, and there is limitation of the airflow. FEF 2575 is a very sensitive indicator of small airway obstruction and a better indicator of a response to bronchodilators because this is effort independent. FEV1, FVC depends on the effort, and if the child is not cooperating, you may not get an adequate result, because if the child is not blowing for more than 3 seconds, then FEV1 and FVC will be very close to 100%. But FEF 2575 is effort independent. So that's why FEF 2575, if it has been improved with the therapy, that means the medium and the small airways have opened up, and the constriction which was there before the therapy no longer is there. So far as the PEF is concerned, now PEF is not a very good indicator for asthma diagnosis. It can be used in some cases for monitoring of the asthma, and especially those who are poor perceivers, or earlier what we used to say, those who are having brittle asthma. Now PEF is an expiratory flow, and again you cannot do it, spirometry you cannot do if the child is less than 5 years. And similarly, PEF also needs cooperation from the child. If the child is less than 5 years or 6 years, the child will not be able to perform properly. And PEF, if there is a post bronchodilator, taking the peak expiratory flow rate value, and after bronchodilator, giving after bronchodilator, if there is an increment of more than 13%, then there is a bronchoconstriction inside the chest of the child. The airway hyperresponsibility, this is objective, replicable, useful. It is methacholine challenge test or exercise induced bronchoconstriction, and more specific than other provocation tests in detecting asthma among the pediatric population. And we normally do the exercise challenge test, and we prefer it more than the methacholine challenge test, because this is much more real life situation. But you need to, this airway hyperresponsibility need to be, you need a very good team to assess this AHR. So these are the 3 objective measurements of asthma control. So far as the control of asthma in children 6 to 11 years, we have already discussed. There should be, these are the 4 parameters we should assess. One is your daytime asthma symptom, nighttime awakening, short-acting beta reliever requirement, and any activity limitation due to asthma. Now, assess the risk factor. Risk factors for poor asthma outcomes are assess the risk factor as a diagnosis and periodically, particularly for the patients experiencing exacerbations, and measure FEV1 at the start of treatment after 3 to 6 months of controller therapy to record the patient's personal best lung function. So these are the initial assessment that you have to do. And having an uncontrolled asthma symptoms is an important risk factor for exacerbation. So there is a more chance of flare-up. If the child is not controlled properly, the chance of flare-up is more. So medications, comorbidities, exposures, and whether there is any psychological problems, what is their lung function status, and what is the other few tests in cases of poorly controlled asthma we do, like blood eosinophilia, FeNO, and type 2 inflammation, or whether it is there or not, especially in adults, we assess these things. Now, specific questions for the assessment of asthma in children 6 to years, they are regarding the adherence. So whether the child is adherent to your therapy or not, you have to ask about the inhaler techniques, and every time you should tell the parents, every time they visit your clinic, they should bring their own devices with them. Adherence is there are any controller medication at the home at present, on how many days does the child use their controller for the weeks, 0 to 4, 7 days, is it easier to remember? You can check that thing by the dose counters. Most of the inhaled corticosteroids and short-acting beta agonists available in the market, they have dose counter. So if you have prescribed a medication 3 months back, and if the child is taking one puff twice a day, and after 3 months, if you see that the dose counter is showing still 80 doses are remaining, normally it contains 120 dosage in each of the inhaled corticosteroids, then that means whatever the child is saying, whatever the parents are saying, the child and the parents are not adherent. Does the child or their patient, a parent or the caregiver have any concern about their asthma? That is fear of medication, side effect interference, because lot of fear factor plays whenever you are prescribing inhaled corticosteroid. And all of you have come across regarding the fear regarding steroid. The steroid phobia is there. So that should be addressed, and those questions should be addressed in a proper way for a good compliance or good adherence. If there are comorbidities like allergic rhinitis, atopic eczema, atopic dermatitis, concomitant food allergy, and very important is your obesity. Because if the child is obese, then it is an inflammatory state. It is a persistent inflammatory state. And in many of the obese children, it has been found that the inflammation becomes neutrophilic. That's why many of the obese children do not respond to inhaled corticosteroids. Other investigations, if needed, what is best and I practice is an asthma diary. Give these a sheet where these 4 pointers are there: cough, need of the reliever, nighttime awakening, and absence to school if the child is a grown-up. And ask the parent just to tick. There should be 30 boxes for 1 month. Ask the parent to tick each of the boxes. If there is a cough, the parent should tick over there. If need of the short-acting beta agonist, there should be a tick. If there is a nighttime awakening, the parent should tick, and against the specific date, and if there is absence in school, or absence or limitation of activity, whatever you deem suitable in your asthma diary. It is very much available in asthma module, ATM module. The last few pages on of the ATM book is on asthma management diary, and there you can give asthma diary, which you can hand over to the parents. Well, assessment of asthma control is much more tough because diagnosis is tougher in younger children. We think and we always think 10 times before stamping a child who is less than 5 years old as an asthmatic. And all of us know the new GINA has said it should be said as a preschool wheeze with low probability, with high probability, with a medium probability. And defining a satisfactory symptom control in children 5 years and younger depends on the information derived from the family members and caregivers, who may be unaware, however, of how often the child has experienced asthma symptoms. Now, basically, it is not asthma symptoms in 5 years and children who are less than 5 years. How many times the child is coughing in a month, how long the cough is persisting, whether the child is having atopic marker, and what is the family history. These are the 4 parameters on which, based on which we diagnose asthma in children who are less than 5 years. So what is the number of time the child is coughing in a month or in a year? How long the cough persists, whether the cough is persisting for 10 days or more. Third, whether the child has any, whether there is any interval symptom, that means when there is no fever, no runny nose, no viral infection, still the child is coughing, and whether there is any family history of asthma, any asthma markers are there, that is atopic dermatitis markers are there. So if these 4, based on these 4 things, we diagnose asthma in children below 5 years. If the child is not having at all any interval symptom, the child is absolutely free, no viral infection. The child doesn't cough when playing or laughing or crying. There is no family history of asthma, and the child coughs only when there is a viral infection. And that also the cough is being controlled very well within less than 10 days. Then most likely this is a preschool wheeze and with a very low probability of asthma in their future life. So, but again, the control assessment is more or less on the basis of same pointers, that is daytime cough, limitation of activity, reliever medication requirement, and any wakening or night coughing due to asthma. Based on them, we classify them well controlled, partly controlled, or controlled. Now, choosing appropriate inhaler device for children 5 years and younger, all of you know, less than 4 years, you have to give spacer, inhaled corticosteroid with a spacer and with a face mask, properly fitting face mask. And there is an alternative device like those children who are completely unable to take the inhalation from a spacer, who cannot cooperate, and in whom there are a lot of neuromuscular problems, or in children who are suffering from many other lung morbidities and neuromuscular problems. There you can, the alternative device, but that is a poor choice, is a nebulizer with a face mask. So ideal device below 4 years, it is not 3 years, it can be up to 4 years. You have to give PMDI with a spacer, with a face mask, but which should be a properly fitted face mask. Now above 4 years, it is always better to give the inhalation with an MDI without a face mask. Because as you put the face mask on, then some of the medication goes through the nose and some goes through the mouth. The medication which is going through the nose is our natural filter of the body, and there are a lot of convolutions in the nose. So almost 50 to 70% of the medication that passes through the nose are being filtered, and especially if the particle size is larger. So beyond 4 years, it is always better to give with a PMDI with a spacer. Without spacer, no question of giving any inhalation. Beyond that, beyond 5 years or 6 years, you can go for dry powder inhalation and or inhaled corticosteroid, that is PMDI with a spacer. And when the child is close to 7 to 8 years, you can offer the child with a breath actuated inhaler. And breath actuated inhalers are very good devices where the drug deposition is as good as a spacer with PMDI. Now, coming to the crux of the problem, problematic severe asthma. Those children who are getting easily controlled, you need not worry for them. But some of the children, despite your most sincere effort, will not be controlled. And you can divide them, I have earlier told you, severe therapy resistant asthma despite of high dose therapy, despite of oral corticosteroid, consider for treatment beyond the guidelines. You may try the biologics. You have to visit. These children should visit a pediatric pulmonologist. You may have to assess the genetics and advise appropriate therapy. But the larger chunk, this is a small gamut of the problem, but the larger chunk of the difficult to treat asthma are revolving around the adherence and the technique. So the additional issues are that comorbid conditions you have not taken care. The child is having allergic rhinitis. Almost 75% of asthmatic children have allergic rhinitis, and if you have not taken care of that. So however sincere you are in your treatment, however adherent the parents may be, the child will not improve. Medication adherence and technique, these are the very, very, very important. And in our asthma training module, these are the 3 Ds, the device, the dose, and the adherence. These 3 things are very important. You have given an inadequate dose, the child will not improve. You have given an improper device, the child will not improve. And the parents and the family are not adherent. And this non-adherence happens more and more as the child's age increases, and they are least adherent during their adolescence. If there are some irritants or some allergens are persisting in the family, in the room, parents are smoking, then whatever, and again the same thing, passive smoking again makes the asthma therapy resistant by shifting the inflammation from eosinophilic to neutrophilic. Allergen exposure, this is very important. And if there is any seasonality, the parents will tell you the seasonality, because many of the cities where there are a lot of pollens during the pollination time. So you can get a history of allergen exposure. So if you are getting that history, you must take care of that. One thing which is often forgotten is if there is a damp wall. That is a very, very big issue so far as the control of asthma is concerned. Environmental exposure, it has been found those children or those families who are residing within 500 meters from a highway where diesel vehicles are plying, it makes the asthma therapy very difficult, because it is far more important trigger and irritant, and again makes the therapy, it makes it therapy resistant. And last, it is a very serious issue if there is any psychosocial issue. The child is psychologically not stable. If the parents are not psychologically stable, there are problems inside the family. Who is going to give the medication? So psychosocial, and not only the psychological aspect of the child, the social aspect of the child is also very important. Now, characterization of the problematic severe, it's a very busy slide. We have divided into 4 aspects. One is your infancy, one is your preschool age. The third is your school age and the adolescence. What is in infancy is the underlying pathophysiology and clinical characteristics of poorly understood things. And if there is any congenital anomalies like tracheobronchomalacia, if there are malacia, the children is having malacia in their air passages, then the child may present as present with recurrent wheeze, which is not at all an asthma. Many conditions due to be considered due to in the differential diagnosis. In these children, the GERD is a very important issue, like laryngeal cleft. If there is a lot of chance of aspiration, which may present with recurrent wheeze. Difficulty in objective documentation in bronchial obstruction is a very serious issue in infancy. And many with problems in the first year of life remit long time in the second year, because these preschool wheezers are not a homogeneous group. They are a complete heterogeneous group. Those children who are wheezing at 6 months or 8 months or 1 year or 2 years may completely cease wheezing when they attain 6 years or 7 years. Many of the children who are not wheezing that intensely during their childhood may start wheezing when the child is at 4 years or 5 years. So this is a fluid state and the condition may change. Preschool wheeze viruses are the most common precipitating factors, as I have already enumerated. Compliance with the management largely dependent upon the caregiver, and especially the problem happens if both parents are working. Some difficulty in objective documentation, yes, it is there, especially if the child is below 5 years. Doing PEF, doing spirometry is very difficult. With lot of difficulty, you can do FeNO, but again, you need cooperation from the child for doing FeNO. The school age allergy is frequent, and this is the age where you get true asthmatics. Symptoms often precipitated by exercise, and that is again a marker of poorly controlled asthma. Evaluation of lung function is easy, but compliance with management still dependent upon the caregivers, because at 6 years, 7 years, 8 years, the child cannot take their own medication. In adolescence, the child can take their own medication, but the child often doesn't tell a correct history regarding taking the medication. As soon as they feel better, they stop taking the inhalation, and they completely tell a lie to the parents, and you can assess by the dose counter that the child is not taking the medication. Tendency to deny the symptoms, they often shy away from their symptoms because it is a stigma for the children. If they take inhalation in front of their friends in the school, they feel very uncomfortable, and they often face a very unpleasant situation in the school. There's a very low compliance, psychological problems, and there are a lot of turmoil during the adolescence, all of us know. And at that point of time, it becomes really difficult to have a good adherence for the adolescents. And assessing the dose and proper device in adolescence is also very, very important. Now, how to distinguish between uncontrolled asthma and severe asthma? Some patients do not achieve good symptom control with regular treatment. In some patients, this is due to truly refractory severe asthma, but in many and most of them, it is due to comorbidities persistent environmental exposure, or psychosocial factor. So to diagnose it is a severe therapy resistant factor, you have to take care of the comorbidity, you have to take care of the adherence, you have to take care of the dose, you have to take care of the device, and you have to take care of the technique. When you are satisfied with all these four parameters, the child is taking the medicine, the device is okay, the dose is okay, the technique is okay, the family is convinced, then only you can think, okay, I am dealing with a therapy-resistant asthma or severe asthma. The common problems that need to be excluded before a diagnosis of severe asthma is, I have already told you, poor inhaler technique in most of the cases. This is a very important issue so far as uncontrolled asthma, non-control of the asthma. Many of the cases you can see, you have given a spacer with a face mask with a PMDI. Now, after some days, the parents come, they have removed the spacer completely. They are attaching the face mask and the PMDI and directly they are actuating the PMDI. Because they think this is a very large device, it is difficult to handle, so it will be easier, it is easier to carry, and the child doesn't get control. Poor medication adherence, we have already discussed. Incorrect asthma, this is not an asthma at all, because initially we have discussed that thing. If the child is having a wet cough, the child is having cystic fibrosis, the child is having a failure to thrive, primary ciliary dyskinesia, immunodeficiency, or persistent bacterial bronchitis, the child is coughing repeatedly, giving inhaled corticosteroid will not give them any benefit whatsoever. If you do not take care of the comorbidities like obesity, like allergic rhinitis, adenotonsillitis, or persistent ER discharge, if you don't take care of these things, the condition is not going to improve, and gastroesophageal reflux also. Ongoing exposure to sensitizing or irritant agents in the home and school. Now, it is not easy to take care of all the sensitizing agents or irritant agents in the home. But what about the school? If there is a dampness in the school's wall, who is going to rectify it? You can complain to the school authority, but you can that the authority will take a very prompt action. That is never guaranteed. And the child is spending almost 6 to 7 hours in the school, so getting ample number of irritants or allergens exposure over there, and the child will not improve. Now, how to diagnose whether there is any allergen or irritant in the school? Because the parents hardly ever visit the school rooms. So it is a very difficult situation, and it can lead to a very difficult asthma, or your whole effort may be wasted. So not going into very details of this slide, guided asthma self-management education and skills training to use the inhaler device effectively is very, very important, either to the child or to the caregivers. If the child is very young, to the caregivers. Encouraging adherence with medication and appointments and over other medications, appointments, and other advice, because almost all of you have failed during this lockdown period. The patient couldn't come, and after that, when the lockdown was lifted, as this year, we are getting much less number of wheezing children, because maybe due to the better quality of the air, they have stopped the medication, and suddenly during the advent of the winter, they are coming with a severe wheeze. At least in last 15 to 20 days, I have experienced 5 to 7 children who were advised to continue the inhaled corticosteroid, who are in adolescents. The parents have stopped the medication because the child was fine, have not contacted any of the physician, and now there is a severe flare-up. So far as the asthma informations, again, the asthma diary and asthma information, that should be a written information for the patients. What are the things to be checked? How to tackle an exacerbation or flare-up? What are the things should be done if there is a flare-up, what the parents can do at their home? Training in guided self-management with self-monitoring of the symptoms or peak flow, a written asthma action plan should be handed over to the parents. The different ways of assessing the adherence, this is a very difficult aspect. None of them are accurate. Most important and most inaccurate is parental self-report. But asthma diary can give you a better assessment of the scenario. Anonymous questionnaire or diary card. That means if you have a clinic attendant, if they call the parents and can get a feedback once in a month, then also you can get some amount of idea whether the child is really good or bad. Pharmacy refill rates, it is very difficult to get access to the refill rates. It is possible in Western world, but in our country this is not possible. Weighing used canister and collecting used inhalers with those counters fairly accurate, but who is going to give you all the exhausted canisters? They normally throw it away. But the dose counter can give you some idea whether the parents have given the thing properly or not. Electronic monitoring devices recording date and time, each inhaler actuation, highly accurate. But there is a very famous study by a very famous pediatric pulmonologist, Nikandar, who has done this study in 2011, where there was an electronic monitoring device but was attached to the inhalation device. Electronic monitoring devices were attached to the inhaled corticosteroid devices, and parents and the adolescents or the other patients in a younger age group were informed that it will be recorded electronically whenever you are actuating. But it has been found when the age of the child becomes more than 9 years or 10 years, almost 50 to 70%, despite of an electronic monitoring devices, they don't take the medication. But this is not possible in our country. This is a research module. This cannot be done in a practical field setup. It is impossible. So digital monitoring has been shown to have positive impact on the adherence, but who is going to monitor? And this device is coming in our country, and maybe it will be available in our country shortly. Then the adherence may be slightly better, and you can assess the control of the situation, or you can assess the situation and whether the patient is adherent or not. You can assess from your phone, where it will be paired with the phone. The digital monitoring device will be paired with your phone. Whenever the child is actuating or the parents are actuating the device, you will get a you will get a beep or any recording over there, and so that you can get an idea whether the child is taking the medication properly or not. But again, that is not a very easy task to do. Now, factors related to the medication adherence, there are two basic pillars. One is your need and the other is your concern. So the parents should perceive the need, and you should allay their concerns about the side effect, about the steroids, about the long-term use, about their, most of the parents will ask you this question, whether it will be addictive or not. So you have to give adequate time to allay their concerns and anxieties. And illness perception is symptom experiences, expectation, and interpretation. Background beliefs, negative orientation to medicines in general, beliefs about the personal sensitivity, and the grandparents are always very, very, very skeptic about the inhalation, its long-term benefit, its long-term bad effects, its addictive potential, and hearing the name of steroid, they always get absolutely alarmed, and they become reluctant to allow their grandchildren to take the inhaled corticosteroid. Now, examples of basic behavioral principles which can be used to improve the adherence: help the parents to develop a behavioral chart or reward system, very difficult. Help patients with linking medication taking with established daily activities, that is mealtime, brushing teeth. This is very practical. I always tell the parents, give the inhaled corticosteroid as soon as the child is getting up from the bed, before brushing the teeth, and after the dinner. Help patients with setting alarms on cell phone or watches. This can be done, but again, the parents should be tech savvy, bit educated, and very sincere. Determine reasonable specific goals defined by the patients. Reinforce patients in a very positive fashion whenever they are coming back. If the situation has been controlled, give a positive feedback, give a pat on the back of the child, if the child is especially if the child is an adolescent, and teach parents to offer labeled praise for adherence behaviors and ignore minor misbehaviors. This is very common. And this is very, very, very practical for any long-term chronic diseases, and help patients with introducing visible reminders at home, because you may put up a chart in the wall where you have to put a tick if the child has taken the immediate corticosteroids. So this is in GINA. All of you can get this thing, GINA. Strategies to ensure effective use of inhaler devices. That is, there are 4 things, that is choose, check, correct, and confirm. But this has been taken from GINA. You can go through and read from GINA. No point of discussing all these 4 things. These are the 4 C's. Training guided self-management with self-monitoring of symptom or peak flow. This is very important for the poor perceivers who cannot perceive a flare-up and land up in the emergency in a very bad state. Written asthma action plan is very, very, very important. If there is a flare-up, what the parents will do. Suppose the parents stay 100 kilometers from your clinic, what they will do. If they are residing in a suburban setting where there is no nearby hospital, what they will do. So you must hand over a written asthma action plan and an asthma diary with very simple asthma diary on the basis made on the basis of cough, need of reliever medication, nighttime awakening, and limitation of activity. If you hand it over them and put a tick on the dates, there should be 30 boxes. Then you can see at the end of 1 month, and you can see on your own how the child was. And regular review by a healthcare provider, your attendant, or as respiratory clinic attendants, if possible. If it is a very difficult asthma, if the child is not improving, then it is imperative for the respiratory attendant to visit the home to see what are the irritants, what is the condition of the housing, whether there are any precipitating factors are there, what are the comorbidities, sorry, not the comorbidities, what are the other factors which is making the therapy so difficult. Comorbidity management, I have already talked with in a length of time regarding the comorbidity, of which most important is your obesity and allergic rhinosinusitis. These 2 you have to take care. If the child cannot lose weight in an obese child, the therapy of or the control of the asthma, the treatment may be very frustrating for the physician. Now, we have gastroesophageal reflux. It is more common. Gastroesophageal reflux is a more serious problem in younger children. Food allergy and rhinosinusitis, upper airway obstruction. Yes, OSAS is a very important comorbidity which should be taken care, and dysfunctional breathing, also called vocal cord dysfunction, where your speech therapy, breathing exercise, and psychiatric assessment is very important. Limit exposure to all these things: tobacco smoke, traffic density. You cannot change your home, but if possible, yes, industries near your home and school, it is not possible to change the home or school within a whisker. Cooking, use of wood and gas. Again, this is a very sorry state of affair in our country, where many of the families still use wood or gas or biomass fuel for the cooking of their daily cooking. Type of heating, any of biomass fuels, if they are using pets, are very controversial, whether there is any role of pets regarding dogs and cats, regarding the ongoing manifestation of asthma or exacerbation of asthma. House dust mite, yes, it is very, very important, and there should not be no carpet at the floor if the child is having a dust mite allergy. Molds, very important. If the walls are damp, it may perpetuate the symptoms. Chemicals used at home for clinic and use of incense sticks and candles. Often, puja part is considered very innocuous and safe and good for the family. But those children who are suffering from asthma, this is absolutely dangerous for those children who are suffering from recurrent cough. Parental perception, attitudes, and knowledge are very important. And it has been found almost 1/3 of the parents in the American Lung Association survey believe that asthma should be treated only when symptoms appear. And there, in that country, in the Western country, where all these things can be assessed in a much better way, where the people are much more tech savvy, where the people are slightly better educated than us. If that is the situation in USA, think what is the situation in India. Role of school is very important, especially the school should be empowered with taking care of the flare-ups and taking care of the condition of the classrooms. So rapid and correct management is vital for cases of acute exacerbation. Every school should have a spacer with short-acting beta-agonist and a mask should be there. School teachers should always be well trained to identify any symptoms of asthma in a child. And children suffering from uncontrolled asthma have a disadvantage at school, having school nurse who can help the child to set up a good care plan. And the room should be well illuminated if possible, and there should not be any dampness. They're less dusty as possible. So the goal of asthma treatment is to obtain clinical control and reduce future risk of the patient. To reach this goal in children with asthma, ongoing monitoring is essential. Parents should be motivated. The doctor should be motivated. The doctor should be patient in answering all the queries and the doubts in the mind of the parents and the grandparents. Adherence to maintenance of the therapy is the utmost factor or the most important pillar in a successful therapy. And the patients and the views or beliefs of the goals of the treatment are essential in monitoring children with asthma. Spirometry with bronchodilator reversibility is of value, should be performed at least annually in those children who are not improving adequately and those children who are experiencing recurrent exacerbations or flare-ups. Clinicians should be aware of the high likelihood of comorbid disorders and especially obesity and allergic rhinosinusitis and dysfunctional breathing and OSAs. When comorbid conditions are recognized, they should be treated adequately. Better control will be achieved within a short time. Thank you so much. Thanks for your time and thanks for your attention.
Thank you, sir, for such a well elaborate session where you have explained on each and every details in terms of asthma management to our delegates. There are many of the questions which has come up. So I'll just take one by one and you can address those. So shall we start, sir?
Yeah, please.
Yeah, okay. So we have first question from Dr. Bishwas, who is from Ranchi. He has a query. He has a 6-year-old patient who has an asthma, and in spite of giving a treatment with MDI, there is a lot of adherence problem. Can he switch that patient to a DPI?
Yeah, definitely. 6-year-old child, you can switch over to DPI very easily. There is no problem whatsoever. But again, make sure that the technique of taking the inhaled corticosteroid through the DPI is proper. Otherwise, even switching over to the same thing, the adherence and the technique, that to be looked for very, very carefully, even if the child is so young, and the parents should be adherent to your protocol and the technique in the child is proper, what you have demonstrated. Yes, you can switch over to DPI. No problem.
Thank you, sir. So there's a query from Dr. Suroji, who says that the child is, he has received a patient who is about 4 years old and 4.5 years old, and he complains of a gastric problem. And there seems to be also an allergy to it. So would it manifest into an asthma in the later stage of life?
Gastric problem, I fail to understand what is a gastric problem you mean to say. Do you mean to say there is a food allergy? If it is a food allergy, then some of the cow's milk protein allergy or some other food allergen sensitization can lead to a persistence of wheezing episodes in their later life. Because if you go through the asthma predictive index, then food allergen sensitization is one of the minor factors. There are major factors and minor factors. So food allergen sensitization is one of the minor factors. So if the child is sensitized and allergic to the food, and that food is being consumed regularly, then there is a chance of persistence of wheeze. Yes, that is there. But if you are mentioning gastric problem means GERD, then it is not related to allergy in any way. So that is a totally different aspect of the problem.
Thank you, sir. So Dr. Sanjay says, Namaskar, sir. There is a patient, as per the Gina says that initially start with inhaled corticosteroid in all the patient whomsoever is being put on beta-2 agonist. So is it necessary to put all the patients as for a maintenance treatment with ICS? Does it really require all the patients?
That's a question revolving in the mind of almost all pediatricians in across the globe. Because in the age group of 6 to 11 years in GINA 2020, in the stage 1, where the child is suffering from a very mild asthma, where the symptoms are very infrequent, where the symptoms are very short lasting, the GINA has, you see, there are two groups. One is your preferred controller and the other is your alternative controller therapy. The preferred controller box is vacant. That means if the child is suffering from a very mild asthma, not having severe symptoms, not having very frequent symptoms, then the preferred controller is nothing. You should not offer any inhaled corticosteroid in stage 1. But in the alternative controller therapy, you will find give a puff of low dose of inhaled corticosteroid whenever you are giving one puff of short-acting beta agonist. Why? Because it has been found that many of the children who have very infrequent symptoms can have a persistent inflammation in their airway. And sometimes if there is an exposure to allergen or bad climatic condition or whatever may be the background cause, there can be a severe flare up and they can land up to a very serious wheezing condition. So that's why the alternative management protocol is that whenever you are giving short-acting beta agonist, you give a puff of inhaled corticosteroid low dose so that the inflammation, ongoing inflammation is being taken care. This advice has been done on the basis of a TREXA study by Fernando Martinez. And the total number of subjects, if I can recollect, close to 400 and something. But we need more studies. We need more studies. This modality of treatment is not the preferred mode of treatment. Till to date, in India, you can practice in a very mild asthmatic, whenever the child is giving coughing, give a dose of short-acting beta agonist. Don't give inhaled corticosteroid. You can give, it will nobody can sue you, but this is not a preferred controller option. This is an alternative controller option. So I will prefer to give short-acting beta agonist. Suppose the child is coughing every after 2 to 3 months. Why should I give inhaled corticosteroid? That's the issue. That is a question comes in everybody's mind. So if you want to give inhaled corticosteroid with short-acting beta agonist puff, there is no harm. But if you don't give, there is no problem at all. So you may not give at all.
Thank you, sir. So there is a query from Dr. Mandeep, who says that in management of allergic rhinitis with an asthma, do we need to test for the allergens? And if yes, which allergen should we prefer? Should we go for testing of 12 allergens or should we go for 48? And what should be the allergen? Should we go for the universal or to the area specific?
First of all, first you have to cut down the total list of allergen that you are suspecting to 12. Because if you take a list of 48, then your life will be difficult. And definitely area specific is most important. And of which most important is your dust mite. And if you want to go for an allergen immunotherapy, then the child should be allergic to not more than 2 allergens. If the child is allergic to many allergens, then allergen immunotherapy is not a good modality of management. So I always go for 12 allergen, which is area specific and definitely including your dust mite allergen.
Thank you, sir. So there is a query says by doctor saying that in management of a severe asthma, can we think of giving an omalizumab, and for how many dosage do we need to give in such cases?
No, it depends. Omalizumab, definitely you can give in severe asthma, and when the child is in stage 5, you can think about omalizumab and other biologics also, but that is not, that is a job of the pediatric pulmonologist. It is better. It is given once in a month. It is extremely expensive. So leave that decision and continuation of that therapy to the pediatric pulmonologist. If you are a general pediatrician, it is better not to start omalizumab therapy.
Thank you, sir. So there is a query from a doctor says that how do you do your management of viral V's? Should we give can we give a beta agonist management of viral V's for earlier subside of the symptom?
Definitely. The acute management of viral V's is always short-acting beta agonist. And it has been found even at a 2-month-old child, the beta agonist receptors are there. So definitely you can start giving beta agonist. But yes, if the child is suffering from bronchiolitis, the benefit of giving short-acting beta agonist will be very minuscule. But if it is a recurrent wheeze, when the child is having wheeze, you are confident about the bronchospasm and you are not sure, and you are sure it is not a case of bronchiolitis. Even in bronchiolitis, after 3 to 4 days, if you see a considerable benefit after giving short-acting beta agonist, you can continue short-acting beta agonist. No problem in giving short-acting beta agonist in virus-induced wheeze.
Thank you, sir. So there is a query from a doctor saying that currently with lot of the webinars going on talking more about uses of inhalation therapy, there are patients who are quite satisfied with uses of a nebulizer treatment. So in that case, and the patient is well controlled, so can he easily switch him to the inhalation therapy, or he should be continued with the nebulizer treatment?
The big no-no for nebulization. Nebulization is not a device. Nebulizer is not a device to be used at home and until and unless there are very specific and very well demarcated areas, like a child who is suffering from cystic fibrosis. You have to give nebulizer because many of the drugs are not available in MDI. So these are the situations, very specific situations where you can think about nebulization. Or a child who is getting drowned because of neuromuscular problem, there you may have to use mucolytics with the nebulization. But what about the asthma? Why you want to give nebulizer? What the dose you are using in nebulizer? 1 puff of short-acting beta agonist, that is salbutamol, is 100 microgram. And what about if you are using levosalbutamol 0.31? So how much the dose you are using? You just think about it. You are using 50 to 100 times more dose, so the child will have more side effects, more tachycardia, inhale corticosteroid. The lowest possible dose, the Rispul that are available in budesonide is 0.5 gram. It is 0.5 gram. But what is the benefit? So definitely the continuation of the nebulization is a very bad choice, I must say. And the child should be definitely put off from nebulizer and put on to, depending on the age, to other inhalation devices, not nebulization. And following this COVID situation, it has been amply described in almost all the protocols that nebulizer should not be the preferred management. And I have seen 2 children crashed because of home nebulization, and they have done nebulization with short-acting beta agonists without oxygen. They died. So please don't encourage doing nebulization at home.
Thank you, sir. So in management, there's a query from a doctor saying that in management of an atopic asthma, how long would you prefer to continue the inhaled corticosteroid therapy?
That depends on the age. If the child is well grown enough, suppose the child is 14 years old, then I will ask the child to continue the medication almost lifelong, because this is an adolescent asthma. There is a very little chance of remission of the disease. You can control, you cannot cure the problem. Now, if a child is very young, say about 6 months, 6 years of old, 6 years of age, then if the child is well for 1 year, then I may think of taking off the inhaled corticosteroid. But with a caution to the parents that if the child again complains of comes with similar symptom, I may have to continue the medication for years together. It depends on the age. It depends on the of the situation. If the child suffers from recurrent flare up, you cannot take off the inhaled corticosteroid.
Thank you, sir. Sir, a doctor says that she has a patient who has come to her with a complaint of a dermatitis, and now she has been treated well with the treatment. But after 6 months, the child has started mimicking the wheezing. So, is that an asthma?
Definitely. I presume what you are talking about, the dermatitis and atopic dermatitis, and those children who are having atopic markers, they have higher chance of developing asthma, definitely. So it can be asthma, and the most likely it is asthma if the dermatitis is atopic dermatitis.
Thank you, sir. So there is a last query which we have. There are many which talks about more of nebulization, and you have answered it to the audience with a very clear demarcation and indication where it should be used and for how long, and what is your overview on it. So there's a query which talks about by a doctor talking about in a child who is below 6 years of age, and in those children there is only for a clinician there is only a clinical diagnosis is available. Can we use a pheno in those kind of patient, since though it is an expensive test to confirm to the parents that a child is suffering from asthma?
Yeah, you can try, but I have done pheno in my clinic 4 years to 5 years. Below 4 years, there's no question of doing pheno because the child has to blow for 10 seconds. So getting an cooperation from the child who is below 5 years is not so easy. And moreover, if the technique is incorrect, it will give an erroneous result. You may try pheno, but again, pheno in our country, the values are not well standardized. You can try, definitely. If there is a big dilemma, you can try pheno. But doing the pheno is not so easy in a child who is below 5 years. You may try. And if it is more than 25 ppb, or if it is 50 or 60 or 70 or 80, then it talks about definitely eosinophilic inflammation. But doing the pheno, the technique may not be so easy for a child who is below 5 years.
Thank you, sir. Thank you, sir, for your today's addressing all the delegates and taking time from your busy schedule for us and answering all the queries to the doctor. I'm sure the delegates must have had a good time with your rich experience, which you have shared with them in terms of management of the poorly controlled asthma in the various stages and what are the parameters which they should keep in their mind while in terms of the diagnosis as well as management, and also more precisely where you have focused more about the asthma diary, which you insist that each and every parents and even the clinicians should also ask the parents to keep a record of it so that it becomes easy for the management. And also you talked about the new electronic devices which can help in the adherence part of the role for it. I'm sure this was quite a value addition for our delegates who are present today. I hand over the session to Shomak. Shomak, over to you.
Yeah, sir. I think I must say that this is a most elusive and elaborate session which you have given to us, and obviously I must say that I think that all the audience have been satisfied with all the queries regarding the pediatric and poorly controlled asthma patients where they are facing day to day in their clinical practice, sir. So once again, thank you on behalf of the entire Lupin Spiritus family to you, sir, for your giving a beautiful speech from your side, sir. Thanks a lot, sir.
Thank you,
Thank you
sir,
so
so
much.
much.
And thanks, Team Lupin, for inviting me here. Thanks all the audiences. Thank you so much.
Thank you, sir, so much.
Thank you, sir.
Yeah.